Dr. Register's not on today. I want to take a minute just to think about her. She's actually fixing to undergo a C-section for her baby. So my thoughts and prayers and our thoughts and prayers are with her and her family in the next couple of days. So we appreciate it. Would like to entertain, if everybody's had a chance to look at the minutes that were mailed out earlier, emailed out several weeks ago, I'd like to entertain a motion to accept those.
So moved.
Second.
Is there a second? Okay, great.
Second.
Any additions or corrections to those? Please feel free to speak up. All right, hearing none. Any opposition? All right, hearing none, we'll take those as approved. Is Liz on the call by chance?
I do not see her on here just yet.
Okay, all right. Let me just go on. We'll go on into old business. Courtney, I think, is going to give us an update on March pause. I'll just take 2 cents for just a second. Had an exciting first course, and I think this is actually going to be a fantastic project. I know it's taken us a while to get to this point, but it really is the potential to, I think, revolutionize the trauma aspect in rural Georgia to where we can really finally get a hold of things and really move it to the next level. So Courtney, if you wouldn't mind giving us a quick overview.
So we did have our first course down at Cordeal. I'd like to thank Dr. Register for arranging a lot of the legwork down there, and that staff, in particular Nita Ham and Cole, who helped us a lot. And I think Becky, who was their IT person, really helped make that pretty smooth operation. I'll be honest with you, I walked in there with one concept of the course, walked out with a different concept of the course, and the fact that we really do need to make it very scalable, because we will have certain centers that may have 20, 25 folks, but we may have a lot of the small rural centers that may have one team, a team of 5 that we'll work with. So we're going to spend some more time looking at how the logistics of that works and how easily done it is. I've got some work to do in the background on trying to figure out budgets for the courses, and that's not something we've got to do right now, but going forward, we need to have a fairly firm idea about how much it costs. We can start looking for long-term funding to do the classes, because I think I'm like Dr. Patterson. I left there pretty pumped up because I thought it was a good day, mainly because we had so many good people there who were willing to put in their time and give us their opinions and ideas. I have secured the building for the 22nd of September, which will be our next ideation of this course. It will be in Swainsboro, at the Swainsboro campus of the Southeastern Technical College. They have a healthcare building there that is very conducive to doing this type of work. So that's where it will be. I hope to send out something either today or Monday and have a March pause meeting, a telemeeting next Friday, same time, 7 o'clock. So I think that's reasonably convenient for a lot of folks, so that we can, I don't want to go through all the details of the things that we're working on right at the moment, because it takes up a lot of time. And I need to get you, I'm working on the slide deck, the comments you put in. I'm working on sending something out so everybody will, 1, see the slide, and 2, see the comments, so that we can work through that. There were some things that we needed to do. I think the concept of putting civilian somehow into the name of the course is essential, because it is different from the military application. And I think going into teaching the things, I think people need to know that it's geared towards their facility there, the work that they do. We did have identified some additional equipment we needed for the practical sessions. I've sent that out for quotes. Hopefully have that back by the middle of the week and get those things ordered. So theoretically, we'll have everything we need at Swainsboro. Karen has been doing some good work in the background. I'm trying to help We have a concept right at the moment of injecting into some of the slides actual links, hyperlinks to a training session, if you will. For instance, if you've never put on a traction splint, getting there that day may be a little overwhelming. So theoretically, we could put in the link to a traction splint, and we would need to do some surveys of the organizations before we get there to find out what kind of equipment they use. So we won't be trying to train them in equipment that they're not used to. I have a concept in the back of my mind about, coming up with a list of the equipment that each center can use. Gail Thornton has been very helpful working on an algorithm for treatment algorithm. That's in the second phase of it. So I hope to finish that up with her and maybe send that out with the email next week. The final course, I think, is October 27th, I believe. It will be at Archibald. And I say the final course, that's the design is the final course of our work towards developing it. That will be the Ready for Prime Time course, and it will be down at Archibald and Thomasville. So I'll try to answer any questions. One other thing, I am playing telephone tag with Linda Grant. Somebody had a really good idea the other day, maybe several folks, about trying to develop CEUs for physicians and nurses. And we hope to work with Glenda and the Rural Innovation Center at Mercer to help us develop that. So if we can get the CEUs for physicians, I think it'll be a lot bigger draw for to get our medical folks in there.
Great. Any questions for Courtney? I do think the CEU and the CME part was a big deal. I think that would do a great draw, and I really appreciate Courtney and all his work that he's done. The session was great. It was a little informal, but we tried to present the information and then go through the individual skill stations to see how how they would work. Not that we went through all the actual teaching, but it was just interesting to lay out the equipment, see how things would work, and what equipment we actually needed and what things and what order kind of they would be taught in. So it was a very interesting process. I think we'll learn a lot more this next session and kind of fine tune things to where we have things available. Did Liz ever come on the call?
I have not seen her on
Okay.
here.
All right.
Hey, Dr. Patterson, I have some of the web-based registry update. I'm happy to
Okay.
get the information that
Go
I have
ahead.
if you want me to. It's
That'd be great. That'd be great, Jeannie. Go right ahead.
because she looped me in on those emails. Unless Kayla wants to give it, but I can throw it out there. She had sent out an email. Right now, we only have 4 centers that have signed on with the web hosted platform. We do have a few. We have one center that was already on it, and then we have a few more centers that were on a web hosted platform, not quite the version that that we had worked with ESO on, that has the outcome module and all that. So I know that there are a few more centers that are working with ESO to kind of get to that piece, so they have that. We do know there are 2 centers that will not be able to do are not interested, and that's just because of their structure. We'll just put it that way. For that, and that's okay. So we do have some following up to do, and the ESO person's going to reach out to those other centers to kind of see where we're at. I had done a survey back at the first part of the year, so there are still a lot of centers left who, from that survey, were interested. There were some who didn't even realize they had gotten money for it. So I think we've still got some work to do to make sure that there's, we filled in those gaps between the contracts and administrators and stuff, and make sure that they understand that, they got some funds, and that actually those funds were earmarked for this web hosted platform for their registry. So sure there'll be some more to come on that.
Okay. All right. Great. The other thing we were going to talk about was the action planning for the Pennsylvania Trauma System Foundation consult visits and the ACS System Consult Rural Focused Review. So hopefully at this point, everyone's had a chance to, or looked at least part of the email. I'm not sure you've had a chance to read all 85 pages of the Trauma System Consult report that was from both Pine Mountain and Cartersville on the January 9th through the 13th visit. And then the Pennsylvania Trauma Systems Foundation report that was from the October 2022 level 4 consultative visits and reports. But there was a, I'm trying to look at the word here. I'm trying to think, an Excel spreadsheet sent out with the major priority recommendations. And the last one, I'm sorry, let me go back for that. There was 11 different priority recommendations. And of these, each priority recommendation was given somebody an area of responsibility or accountability and a committee to work with. And the last one is the rural domain. It is the largest of all the 11 because it was centered on rural consultative visit. And we have actually been given the responsibility to look into that as far as the level 3, level 4 committee. And there's several bullet points that I wanted to go through today and talk about. The first one, and I'll entertain any interruptions. Please feel free. But the first part of that was to perform a comprehensive resource and needs assessment addressing several points. One of those is funding for rural trauma centers, emphasizing the rural aspect of EMS and trauma hospitals. Now, we've done the published review of the level 3s and 4s as far as the hospital, and that was the financial survey we did last year. We published that in the Journal of Trauma. We presented that at the AAST. It's been presented at the GQIP-TQIP GTC meeting as well. So we've done that part of that. We kind of know what the year-to-year costs are. We don't know what the startup costs directly are, and we've talked about that before. But at least we're well on our way into the hospital cost at this point, and would like to revisit that cost, of course, in about 5 years' time is what I'd hope to do, so that we could look at not only the inflationary costs, but any new recommendations that come out from ACS as far as it affects level 3s and level 4s. But then also we may get a little bit better reporting, because we had some underreporting, and we know that, especially with the level 4 centers that just may not realize some of the costs that are involved. And when they have multiple people, or excuse me, one person splitting multiple jobs, they may not have divided that as well as they should have to really reflect what their costs are. So I imagine that's going to go up, and I wanted to repeat that in 5 years. The problem is we have no way of figuring out the aspects of EMS in the state right now, and we need to come up with how to capture EMS as part of that comprehensive resource and needs assessment. Any thoughts on that? Courtney, I'm kind of looking toward you on this as well.
So we have been working on that, Liz and I and Nina Ham, on a couple of different ways. One is that the Georgia Association of EMS and State Office and some other folks have been doing, they've had 2 this week, town hall meetings with EMS in each of the EMS regions. I went to the one in Sylvester, I think Wednesday, and I'm going and talking to them a little bit about March pause, but more interested in listening to them in barriers to making those hospital transfers and barriers to actually picking up the patient at the scene and taking them to the appropriate hospital. I got some feedback when I was there Wednesday. They had another one Thursday. I was not there, but I talked to several folks who were there. And so we're getting some information from them on that aspect. We also set up a meeting. We actually did down at Cordeal at the Rural Health Center at Nita's office. But we involved the ACCG, the Association of County Commissioners. They had a representative there. We had a representative from Georgia Hospital Association who does the Rural Center of Excellence work. some EMS people, regional people from the state office of EMS were there. Had a guy from the helicopter service, a couple of EMS directors, and some ER folks, and looking at we haven't got a plan yet. We're not at that point. We're looking at trying to, from both sides, look at what are the barriers to doing that. And from what I've gathered from both of the things, there are some attitude areas, some attitudes that we need to address. But the biggest thing is they're concerned about resources, and they're concerned about making those transfers or making those long trips and leaving their counties uncovered. So we're getting some information. I think going down the road, we're going to have to get a little bit more finesse about how we pull the data in so we can actually use the data to figure out what's going on. We're also working with Glenda Grant at the Mercer Center to develop well, let me go back. Let me stop. Liz and I have a telemeeting Tuesday with Kelly Joyner from State Office of EMS. We have a spinoff that we're funding through the March Pause grant to actually identify where each 911 EMS base location is. And to my surprise, that doesn't exist in the state of Georgia. There is no single listing. So we're going to work with Kelly Joyner. They have the data. It's reported when they do your license every year, but they never compiled it into a latitude longitude thing to put it on a map. So that's what we're going to be working on there. So we'll actually know where the centers stations are. And then from there, we're going to try to figure out, okay, we got a station there. How is it staffed? You know, they have one crew in that county. Is that all they have? And a lot of the counties have one crew on duty. So that is a huge issue. So we're also working with Glenn Grant on some of the hospital side to do the survey about, what equipment do they have and what issues do they see in getting patients out in a timely manner? How much of getting them out is a receiving facility, not able to take them or not willing to take them or whatever, or how much of it is EMS and how much of it is internal processes. So when Liz and I talked with Nita, she said, well, that we've all decided that we need some specialists to design the survey tool so that as we get the information we can utilize it. So Glenda Grant's got folks at Mercer that do that. So she's offered to help. We just got to get the initial questions to them. I've got some of the questions done, and Liz sent me some information and Kelly sent me some information. So I'm trying to get that in one document, get it Glenda so they can start working on it.
Great. Thank you, Courtney. The other part of that, the performance of comprehensive resource and needs assessment, was looking at an evaluation of the rural trauma capacity to identify gaps, including EMS, trauma hospitals, and transfer capabilities. And that's part of what I think Courtney was talking about. We've also discussed getting UGA involved to do a geo mapping study, which is essentially what almost you're talking about, but including not only the EMS, but trauma, hospitals, and transfer capabilities. And so that's what I'd kind of like to partner with you on to some degree so we can talk about that at the upcoming meeting, I think in August, about getting UGA involved in geo mapping the entire state so we understand what's going on as far as where everything is and how it's located and overlaps. Any comments about that? I think that will be very interesting to look at from a perspective of where everything is. Now that we know what costs are, we can go on to figure out where everything is right now. And the map is changing. There's several centers that are trying to come on. We're trying to see if they really understand what they're getting into as well. Any comments? Okay. The next one was, I think, one of the hardest ones to me. It may be the shortest one in this column. Was recruitment and retention, primarily focusing on rural providers and nursing. I don't know how to solve that at this point without getting involved with the individual medical schools and the individual nursing schools around the state and kind of looking at it, maybe doing a pilot region and maybe a pilot study. But somewhere we need to get involved with how we can ultimately look at rural providers and recruiting, because this is something the medical schools are doing a lot. I know from the positions I have at several of the medical schools in the state, and most of the increase in medical education in the state in the last couple of years has been all related to rural focus at this point and things that have been done. So we probably need to get in touch with the individual medical schools and kind of look toward what we're doing. Any comments there? All right. The next major heading in this area was the ensure involvement and participation of rural trauma hospitals and EMS in an inclusive Georgia statewide trauma plan. I do remember, the one comment that was very interesting to me at the focused visit meeting at Pine Mountain was, that everyone, there's a state plan, but a lot of people don't know what it is, and I don't know what it is. And so I think we need to have some transparency with the GTC about a plan and what's going on with that plan, and then seeing where we're fitting into that at this point. So we need to work on that and follow up with the state and the GTC at that point. The next major area they wanted to look at was standardized trauma care in rural Georgia through educational programs. And that was basically what we're doing with March Pause. So we've really got a good handle on that right now and a good idea. And I think with moving forward with that, we will be able to change that as far as the meter on that dramatically over the next 18 to 24 months. Courtney, do you have anything to say about that? I think it just dovetails exactly into what we're already doing.
No, the only thing I agree, I think is dovetailing right in, because if we can develop a standardized approach and push that across rural Georgia, so both sides of the ER door are on the same plan and on the same team, and I think that will go light years towards improving trauma care in rural Georgia.
Great. The next major area was improve the capability to manage injured patients in the rural environment by increasing the complement of emergency medicine providers and improving competency of existing providers in rural emergency departments. Really think that also dovetails into the March Pause process. But I think we need to figure out, I think through the geo-mapping process and re-looking at that geo-mapping process about every year to 18 months, where we're making a difference and where things are changing, and look at the differences over time to look at what's going on in the state and keeping up with this, not just doing it one time, but ultimately, we make a big difference in the next 2 years and then everything falls apart. And 8 years later, we're redoing the whole process again. We need to do something to make sure that this continues for perpetuity's sake. Any comments on that area? Okay, then the next two I'm going to kind of put together, but improving scene response times by bolstering existing mutual aid agreements and addressing staffing shortages. That also kind of looks into that area of recruitment and retention, of course. But then the other part of that was develop a process for rescue stops and accelerated transfers in rural areas. There's a very interesting article that came out that Kelly Vaughn had shown me, talking about this process called a red box transfer. And this was out of, I believe, California, in one system in the mountains in California, where they covered about 25,000 square miles area, 2 different trauma centers, and one was a level 3 and one was a level 2. And they came up with a sheet, and they had put at the top in a red box what they considered priorities about transfer. So they came up with this system where a center would call and say, the transfer line of the other center and say, we have a red box transfer. They stopped what they were doing. They transferred them immediately to the person that was in charge for trauma at that point, and they immediately started doing it. At the same time that they were calling the trauma center, somebody else at the transferring facility was calling EMS and immediately asking for transport at that point. They hadn't even had acceptance yet, but they knew they were going to get acceptance at this point automatically related to this red box transfer. And they were looking at each one of these transfers. And maybe something we need to look at through the trauma medical directors committee about transferring things, how things are transferred, but ultimately trying to get a system in Georgia where we, you know, when somebody calls and says magic words, whatever they are, you know, have a red box transfer, then that person is immediately put to the trauma surgeon at its own call, or to the TMD or the ER doctor that's accepting at that point, and they can go ahead and they can ensure that somebody's going to take that patient immediately at that point, so they can go ahead and call transport so we can decrease times. What was dramatic in this study that they did, they went from the goal in the state of California was 60 minutes for transfers, and they were at 122.2 minutes, if I remember correctly. And within 1 year, I think they decreased that to 59 minutes. And so it'd be interesting to see what we could cut off, in essence, in some of our transfer times. And this is what Courtney's been talking about this morning as well, and is a big topic of conversation all over Georgia about these transfer times. Any thoughts on that?
Hey, Dr. Patterson, this is Karen. So the PI subcommittee is, we actually discussed that red box briefly on the last meeting. It's something that we're working towards, time to definitive care, and, you know, in particular transfer times, what we can do to shave off minutes at our own facilities. That's our primary focus of the PI subcommittee right now. So we're really in, you know, we've only had 2 meetings, and so we're really in the infancy of working on that. But that's absolutely a study that we're looking to for some guidance.
Great. Karen, who was that again that was doing that? The PI subcommittee?
Correct.
Okay. Any other comments on that? All right, and then the last 2 things on the list of needs were provide education and collaboration opportunities for rural facilities to achieve proficiency regarding data entry and validity. And I know that the GTCE is working on that through their mentor program at this point. So that's already, I think, got a little bit of responsibility given toward the GTCE. And then the last one was provide rural trauma program managers process improvement training along with mentorship and support from other facilities. And this also, the GTCE mentor program has this involved as well. So both those are being, I think, well taken care of directly. We may just need to ask them to give us a report, since we're going to be the committee that's responsible for these priority recommendations. Any comments on that? Kelly, would you have any response on that, since you're involved with that, I think?
Well, I think from our perspective, Tracy Johns is kind of heading up the mentor program. And so I'm the registry subcommittee chair. So as we move forward, I'm sure we'll be working together to advance both of those initiatives.
Okay. What I would like to do is, if we can get together sometime in Savannah as a group to sit down and talk about these things, so that we can kind of put our heads together and push forward. We also need to plan. I've forgotten personally, have we gone ahead and published the list of meetings for next year as far as the quarterly dates?
We
I don't
have,
think
yeah.
so, have we, Gabby?
No, I think for the August meeting, they're looking to approve the commission quarterly meetings, and then based off those, the committee meetings will be, I guess, cadenced out.
Okay, great. Thank you for that update. I couldn't remember if we talked about that or not. So we'll hopefully get back together and see where we are and hopefully start to farm out some of these priority recommendations that we can start working on, that we can come back and give reports back to the GTC at a later date. One more thing that we've got going on, our annual project to assess specialty care. We'll have our review in August. We'll be giving out a survey again to all the centers so we can compile that, put that back on there, and that should hopefully be back on the website with Gina's help, with a QR code that you can scan, and it'll be the next updated process for the next year of who has what, and what it, how that is, you can call to find out, or you can call if someone needs replant services or ECMO services, or even, who to get in touch with at Grady or Cartersville. We can get all that stuff online. We would have a copy of the transfer number, the TMD, the TPD, all the different things that we need to know about a program so that we can call and communicate and improve our communications. And we'll do that at the August meeting. Did Liz happen to come on the line so we could talk about the GTC updates?
I don't believe so. No, I
Okay.
do not see her on the list.
Okay. Anybody have any other comments or other business that we want to discuss? All right. Hearing none, want to give everybody a few minutes back of their morning right now so we can compile things. Looking forward to seeing everybody in August, next couple of weeks. Please feel free to text me or email me about anything that's going on. Dr. Register has boldly planned that she will probably not be there, I think, at the GTC meeting, but she'll be in the King and Prince at the Georgia chapter meeting. So I think we'll have good representation at both meetings. If we're pretty much done, we'll go ahead and move for adjournment at this point. Anybody?
Dr. Patterson, Dr. Register just chatted, good morning, on the meeting chat.
kidding.
So, no, I'm not.
Let's see
Well,
if
I
it'll.
hope she's doing okay.
Morning.
Let's just look at her. There she is.
Hey, we're about to get started. I'm just saying good morning. I mess with y'all.
Good
Well, good luck,
morning.
Alicia.
Thanks for running the meeting this morning.
No problem. We were thinking about you.
All right, thanks guys. Have a good one.
All right. Bye-bye.
All right, bye.
So any other comments on the meeting or the
Hey,
agenda?
Dr. Patterson, Tiffany from Floyd also said that they've got an enterprise rural team focused on rural provider recruitment and retention.
Oh, I'd love to hear about that.
Looking specifically at compensation and making good progress. So maybe Tiffany, in August, if you're in Savannah, we can talk.
Tiffany, I'd love to talk to you about that.
Hey, good morning, Dr. Patterson. Can you guys hear me okay?
Yes, ma'am.
I'm actually in Ohio. My son is competing in a national sporting clays competition. So the
Good
Wi-Fi
luck. Good
is,
luck.
thank you. The Wi-Fi is a little spotty here. But yes, we have a enterprise-wide team working on rural provider compensation, looking at multiple different things. We actually did a provider survey with in our rural spaces, and I don't know if you guys know, but we're part of Atrium now, which is also part of Advocate. So we have actually quite a large array of information available to us now. So we have our enterprise consists of, the Georgia, Alabama, the Carolinas, and most recently some facilities in the northern Midwest, to include like Milwaukee and Chicago. So we actually are blessed to have all this information, but we have an enterprise-wide rural committee working on, and we've actually divided into two subcommittees, one hospital-based and one ambulatory. And so, yeah, I'd be happy to share with you guys. We're actually making very good progress. And there's a hospital in Stanley County that is being used as a pilot for multiple different initiatives, and they actually did some pretty innovative things during COVID for trauma care that we can try to pull together and share with you guys.
Okay, that'd be great. I really would appreciate that. All right. Any other comments? I'll ask for a motion for adjournment.
I'll give a motion. It's Kelly.
All right. A second.
I'll second.
Thank you. So everybody have a great weekend. Be safe out there, and look forward to seeing everybody in August.